don't see others waiting to be admitted to the webinar. So welcome everyone. Thank you for joining today. Welcome to our Canadian Guidelines for Post-COVID-19 Condition, CAN-PCC webinar series. We are very excited to have you all here today. My name is Wojtek Wierczok. I'm an assistant professor in the Department of Health Research Methods, Evidence, and Impact at the McMaster University Grade Center and our Michael G. Groot Cochrane Canada Center. I'm also a methodologist serving on the Pediatric and Adolescent Guideline Topics guideline for the CAN-PCC project. And for today, I'm joining you in the role of host or facilitator. And joining me are our excellent collaborators for this project, Dr. Eddy Lang and Heather Evanoff. Together, they will be walking you through the recommendations related to the Pediatric and Adolescent Topics guideline from the Canadian Guidelines for Post-COVID-19 Condition. And I'll start with a short introduction here for Eddy and Heather. Dr. Eddy Lang serves as the guideline methodologist for the CAN-PCC Pediatrics Guideline team. He is a professor and department head for emergency medicine at the Cummings School of Medicine at the University of Calgary and in Alberta Health Services, Calgary zone. His areas of interest are knowledge translation, evidence-based medicine, and operations research. He is an InGuide Level 3 certified methodologist and a member of the GRADE working group, and has led the development of GRADE-based clinical practice guidelines in pre-hospital care in Canada and the US, as well as with the International Liaison Committee for Resuscitation. Heather Evanoff is our CAN-PCC patient representative who has served on the testing identification and diagnosis guideline team and on the pediatrics guideline team. In her employment, she is an aquatic supervisor and leadership instructor for the city of Mississauga in Ontario. As we begin, we would like to acknowledge that the work of the CAN-PCC project takes place across Canada, a land that is the traditional, ancestral, and unceded territory of many Indigenous nations. From coast to coast, these lands are home to the First Nations, Inuit, and Métis people, who have stewarded them for millennia. We honor their rich cultures, languages, traditions, and histories. For our McMaster University presenters, myself, we recognize that McMaster sits on the traditional territories of the Mississauga and Haudenosaunee nations within the lands protected by the Dish with One Spoon Wampum Agreement. And as we get started, we'd like to take on some housekeeping issues. For the purpose of today's webinar, please submit questions using the Q&A feature at any time. You'll be able to access that at the bottom of the Zoom window in the menu. We have set up the webinar in order to take all the questions through the Q&A and not also the chat to help us organize the questions and help us to make sure we address all of these submitted. So please use the Q&A feature, and that's the best way to submit your questions. And thank you to those who submitted questions in advance during the registration. We'll look to address those as well. In the presentation, you'll see, just as on this slide, wherever possible, the slides are presented both in English and French. For some of the more complex slides, we will present the English version first, and then we'll just show briefly the French version. But a recording of this webinar will be available on our canpcc.ca website, and the slides will be made available. So you'll see all the slides in French as well. Now for the start, I'll pass it over to Dr. Eddy Lang to help introduce the topic.
Thank you so much, Wojtek. It's a real pleasure and an honor to be able to present to you at this CAN-PCC webinar dedicated to pediatric and adolescent topics. And thanks everyone for the great questions. I hope to leave us lots of time to address those. So let's go ahead. Next slide. My disclosures, I do want to state that I do receive consulting fees for WHO guideline methodology work, and Heather Evanoff does not have any relevant disclosures to share with you. Next slide. So this is what I'm going to try to cover in the next 40 minutes or so. In full transparency, I have to tell you that there have been a number of challenges in developing these guidelines. The process has been fascinating. The conversations and discussions have been excellent, and often sometimes heart-wrenching to hear what the suffering is with regards to this condition in pediatric and adolescent patients, and how controversial some of this work is. Second objective, I want to focus on the methods that we use so that we can give you a sense of all of the steps and investment that went into coming up with the best possible recommendations with the methodologies that we have available to us at this time. I'm going to share a number of the recommendations that have come out through well over a year of work and meetings and discussions. There are still some that are going to be finalized in the next several days and will be available on the PCC website, and you'll be able to see those as well. And we will, from a practical point of view, talk about how these recommendations can be incorporated into practice, both at the policy level, and as you'll see, specific to school administration, because of course, as a pediatric and adolescent topic, the issues of schools and school accommodations is so essential. Next slide. So PCC is, or also known as long COVID. Remember, it's still a relatively new condition. You know, in medical science and in pediatrics, we have illnesses and conditions that have been described for decades, and if not well over 100 years. This is quite new, and that is in some ways presenting part of the challenge, the novelty of it, and the moving target nature of it as well. As you can imagine, the incidence of COVID is difficult to assess because of the changes in testing patterns. The number of clinics that are available for PCC patients are also changing, raising some challenges in the accumulation of new relevant research. But as you can see from this slide, it is a far-ranging condition affecting many parts of the body. Next slide. Let's focus on the WHO clinical case definition so that we're all on the same page. And this is for children specifically. So we need to see a history of confirmed or probable SARS-CoV-2 infection, obviously. Important that the symptoms will have lasted for at least 2 months before we consider this diagnosis, and that the symptom onset should be within 3 months of acute COVID-19. So those have been around, that definition has been around for a while, and is still very relevant today, although, as I mentioned, a bit more challenging to definitively apply. There are a number of symptoms. I'll go over those in more detail. Fatigue, anosmia, the inability to smell or smell properly, or distortions in smell, anxiety are the top 3, but there are many others. And it's important that there is an impact on everyday functioning, and that is inherent to the definition. And there can also be a new onset of these symptoms after an initial period of recovery, or it can be persistent from the time of the initial infection. So the fact that there was an intermediate period of improvement does not exclude the diagnosis. Next statement. Next slide. So this is huge. These are estimates from as recent as last year, and the global impact of PCC has been incredible. 400 million individuals are believed to have had PCC at one point in time or still suffer from PCC. Next slide. There is, of course, a lot of discussions as to the mind-brain dimension of PCC, but let's make no mistake, there is clear pathophysiological and biological dimensions to this disease, even though there are often psychological manifestations or components of it. So these are some of the things that have been shown quite clearly in basic science settings as to be the underlying pathophysiology of long COVID. They include immune dysregulation related to persistent infection with viruses. And this mimics some of the post-infectious conditions that lead to long-term sequelae in other kinds of diseases or infections. We know that there is a gastroenterological component, and that is going to feed directly into one of the recommendations that we're going to be discussing. The microbiome has a dysbiosis, or an alteration in flora related to long COVID. There is an autoimmune function within PCC that has been identified in studies that have looked at this. I remember working in the emergency department, we would see patients with acute thromboembolism related to COVID infections. But this is not just true for acute, this is true for long COVID. There are microvascular blood clotting dysfunction that persist in the PCC state. And there is, of course, neurological sequelae. There's disturbed and dysfunctional signaling involving the brainstem and the vagus nerve. So clearly there's a biological basis for PCC, but there are also numerous manifestations, including those that have psychological components. Next slide. So we clearly have appreciated through the year of deliberation and the meetings that we've had with our guideline team that it's a new condition. It's a significant burden on society and healthcare systems as it relates to children. And we still haven't exactly pinpointed a precise confirmatory approach to diagnosis, or a lab test, or something that absolutely establishes the diagnosis without a shadow of a doubt. And there is clearly a need, because of the public health burden, to establish an approach to how to deal with this in children and adolescents, because it's, as is true for all of pediatrics, they're not just small adults. They require a unique and specialized approach when PCC is being considered or diagnosed or managed. Next slide. So this is where we are at in terms of understanding the epidemiology of PCC in the current state. This is from data going back to 2023. Look at the range. We think that the number of children that are affected by long COVID annually may be 1,700, which is still quite significant, but it could be as high as 43,000, and that's demonstrating the variability in the kinds of research that is out there that has looked at that. US studies, and this is something that you can extrapolate because we're roughly 10 times the population, they're estimating that there's about 300,000 children with PCC, and that would come to about a 29,000, which is about middle of the range for Canada. And another important thing to remember is that almost 30% of adults who have recovered from an acute infection, this is earlier data, of course, demonstrate signs and symptoms from PCC. There is a fair bit of research to show that this is probably not as high in children. It's probably closer to the 5% range, and that's still extremely significant given how widespread the infection is. But the likelihood of contracting PCC after an acute infection is not as high as it is in adults, but still that creates a significant public health burden. Next slide. So currently the belief is that, our understanding is that 1 in 9 adults, that's 3.5 million Canadian adults, have experienced long-term symptoms after a COVID-19 infection. And I'm sure you have, either you yourselves have suffered from this. We learned a great deal from our patient partners in this project about what that was like, and you'll hear more shortly. But that is an incredible number of individuals affected, meaning that 600,000 adults have these long-term symptoms and have missed school or work, sometimes for prolonged periods of time as a result of this condition. And this is something that we had never seen before in the history of modern medicine. Next slide. So this is developed with the help of the methods, the content co-chair for the panel, Dr. Anu Apadwa, who synthesized some of the key symptom profiles in pediatrics. As you can see, there's quite a number of them, but the PCC manifests in these prominent ways in children. Fatigue is a big component, and you can read the other ones as well. A very common feature is something that came up over and over again, and we have specific guideline recommendations and questions to address this, and that is the brain fog or the cognitive or the concentration difficulties that are associated with PCC in children. There's sleep disturbance, there's the pain, the joint pain, the exercise intolerance. Now, one of the most challenging areas are the psychological. And this became quite an area of distress and controversy and discussion on the panel. We had mental health professionals who were providing excellent input, but it often would get interpreted as the minimization or sometimes referred to as the gaslighting of patients with PCC because their symptoms were attributed to psychological causes. I don't really think that was the case. I think what was happening was that it was a recognition that PCC is a difficult condition. It can often result in psychological counting. Doesn't mean it's caused by a psychiatric disorder, but the coexistence of psychological conditions means that mental health resources are important. Next slide. So I'll turn things over to Heather, who is going to speak about the patient and lived experience with PCC.
Thank you, Dr. Lang. I just wanted to start by sharing some thoughts from another patient representative, Kimberly. As a person with post-COVID-19 condition, I'd like to see clinicians consider these guidelines in their practice. I'd like to encourage sensitivity when patients are expressing those concerns. And I'd like to see the public use the guidelines to best inform and empower themselves in these health decisions. I just wanted to take this opportunity to share my personal experience with PCC. After having my first infection at the very beginning of the pandemic in February 2020, I began to notice several changes relating to my energy levels, how often I was getting sick, my inability to no longer be able to tolerate higher temperatures, and many symptoms related to my respiratory and cardiovascular symptoms. I went from being a very active, busy individual, both at home and work, who was cycling more than 50 kilometers, as well as swimming several times a week, to having to push harder than I ever had before to accomplish a fraction of what I was able to before, and which got progressively worse the more that I pushed. After going to my GP several times throughout the course of that year with concerns about the changes that I was experiencing, I was dismissed and told that I was getting older, needed to consider less stressful sports less frequently, and consider adding yoga and meditation in regularly. Fast forward 5 years and a total of 6 COVID-19 infections later, despite being very cautious, and my life has been turned upside down. I'm no longer able to push through anything physically or cognitively without experiencing severe repercussions due to PEM. I've been off work and on disability leave since January 2022, and my ADLs have been drastically modified to be able to cope with all of the chronic conditions that I've been diagnosed with as a result of PCC. But most of all, my family has had to learn to adjust to the monumental changes in what I'm now able to join them in. I've had to learn to educate myself on conditions that I had never previously heard of, to learn how to advocate for myself in order to navigate the medical system, and how to deal with all the changes that I've experienced. What inspired me to get involved with CAN-PCC was that through the process of education and advocacy, I was met with numerous roadblocks and realized the gaps in knowledge and acceptance around PCC and post-viral illnesses in general. I experienced times of resistance and doubt by the medical community due to a lack of measurable data, and I wanted to be able to use my experiences to help provide real-life perspective to help contribute to the understanding, education, and awareness of PCC in policy creation and throughout the medical community. While working on the guideline team, I was always asked for my opinion and felt valued. I was asked how my lived experiences related to the recommendations being discussed, as there's still so much that we don't understand or have answers to. Next slide, please. My message of hope for patients, health professionals, and policymakers to take away from these recommendations is: to the patients, you are not alone, and what you're experiencing is real. No one knows the experiences of their own body better than the person living with it. Continue to learn and advocate for yourself. To the medical community, be open, empathetic, and validate your patients. Take time to self-reflect and consider alternative pathways. It's okay not to know or understand as long as you're committed to finding out together. Be humble and supportive using the knowledge and skills that you have, and don't let preconceptions, stereotypes, and opinions overshadow what you know or are exploring. And to the policymakers, PCC has changed lives. As we heard, it's estimated that as of August 2024, over 400 million people worldwide have been affected by PCC, and every day that number continues to grow. Please continue to foster learning, understanding, and create opportunities to find answers, acceptance, and treatments to this debilitating, life-changing illness. The last thought that I'd like to leave everyone with is that not all disabilities, such as PCC, are visible. However, that doesn't make them any less valid. Looking at me on most days, you wouldn't know the life-changing disabilities and chronic illnesses that I've developed and now live with as a result of PCC. People often comment on how great I look, which, well-intentioned, can be triggering and dismissive. My hope for the future is that regardless of how we perceive and see people, that we seek to understand, be open-minded, remove stereotypes and preconceived notions of what illnesses and disabilities look like, and treat people with kindness and compassion. Back to you, Dr. Lang.
Thank you so much, Heather. Those words speak volumes for the experience of PCC, and I really want to thank you for sharing those really insightful comments. So clearly, with such a problem on our hands in healthcare, we were so pleased that the Public Health Agency of Canada developed a program and funded a collaboration between the GRADE Center at McMaster University. GRADE is the methodology that we use to create these guidelines. Cochrane Canada, who is part of an international network of evidence synthesis, to put together this very impressive and immense project that you can learn about on the website. Next slide. Over 150 people were involved in this project, covering a range of expertises. It became clear that this was going to be a very complex guideline and required lots of specialized input, including, of course, persons with experience in PCC, including the parental perspective, which would be so important for guidelines related to children and adolescents. And we also needed to know not just how to put out the recommendations, but how to move them into practice and share that information, which is one of the products being the webinar that you're attending today. Next slide. Ultimately, after much deliberation, and I'll show you these in a few slides, we whittled it down to 6 guideline teams, all focusing on a specific topic related to PCC, and all of them had a diverse range of experts on board to help us move to recommendations. Next slide. We had 1 or 2 patients involved for each of the 6 guideline teams, and you see some of their photos here. They provided the very wise and sobering often input that we just heard from Heather. Next slide. So this was the pediatrics team. We had people from all over the country, West Coast to East Coast. Laura Frego is the parent of a child with a chronic post-infectious disability. And I really want to issue a special thank you to Wojtek, my methodology co-chair, and Dr. Anupma Wadwa, who did an incredible amount of work bringing all of us together. And I'll show you on the next slide what the backgrounds were of these individuals. So we had 14 members. You've met Wojtek and I as the methodologist, but our medical expertise came from mostly pediatricians, specialists in infectious diseases, neurology, psychiatry. We had a nurse practitioner and a neuropsychologist. And all of these perspectives were essential because we wanted to do the best we could to create recommendations that would help the affected population. Next slide. So we aimed as best we could to have balanced representation, that all key stakeholders were represented. And, you know, we always understand with guideline processes that not everyone will agree necessarily with our final recommendations. That would almost be impossible. But at least through the grade process, we can show everyone how we got there. And one of the things that you'll see with the recommendations are these tools called evidence to decision tables. It's not just enough to look at the studies and see what the evidence shows, but there are a number of very special criteria to think about to move from evidence to recommendation. And all of that is laid out, as well as standardized training for all of the panel members with a program called InGuide that allowed us to all work pretty much on the same page and understand how to move forward. Next slide. This is a more detailed analysis of the methods we used. This 8-step process begins with input from our government and our government sponsors, patients in the public, other health organizations, and it's really quite challenging to whittle down to decide on what topics and questions we were going to focus on. It just required a lot of navigation. Wojtek was essential here to see what was happening in the adult groups and the adult PCC groups, so that we were synergistic and not conflicting. The key thing about the grade process is that it really focuses in on outcomes. So it's not just enough to lump a bunch of studies together, but we had to define and prioritize what was important. Was it getting back to normal cognitive function, normal exercise ability? Was it psychological measures, return to school? So identifying those and prioritizing them was really important, and that was where we invested time in step 2. And then, as you can see, through these 8 steps, we developed the draft recommendations, always put them out for public comment, and then reviewed and revised these recommendations based on that input. We had a really impressive governance process, and you see that on the right side of the slide. So we had our 6 guideline teams. We had an overseeing panel called the Guideline Development Group, but we also had specialized oversight committees focusing on equity. We had public member panel, the knowledge mobilization group, and the evidence synthesis team, as well as an international advisory board. And all of these various committees reviewed the draft recommendations and the processes that we were following to make sure that they were up to date and as best as we could do with the tools we had available to us, and with often the limited evidence we had available to us, since a lot of it did come from the adult world. Next slide. I'll focus specifically on equity. We know that in healthcare in Canada and around the world, equity deserving groups, and they're listed here, often get a poor shake when it comes to healthcare delivery for a variety of longstanding reasons. So it was really important to us from the get-go that these populations receive special attention. And for every single recommendation we considered, we looked at, well, what would making this recommendation do? What would it be its impact from an equity perspective? Would it make the world a fairer place or a less fair place? Are we proposing treatments that are more accessible or less accessible? And all of that, all those criteria were a lens that were applied to everything that we do, so that we left no one behind that was suffering from PCC and also belonging to one of these groups. Next slide. So these are the 6 teams that finally came together, and there was really good collaboration from these teams. I think each of these teams has put on a webinar. This is number 7. So after much deliberation, we focused in on these 6 topics. Prevention worth a pound of cure was first and foremost. Diagnosis was a big project for that group. And we were so pleased that there was early recognition that this was a different entity for children and adolescent, the implications, the treatments, what we would be doing and recommending would be different. So we were very pleased to have a dedicated topic and team to pediatrics and adolescents. Next slide. So this is Chief Scientific Advisor for Health Canada, Dr. Mona Nemer, saying that it's about more than just the research. We can flip through studies and compile numbers all day long, but the input from those living with PCC and their daily experience was an essential voice and lens through which we considered our work. Next slide. In the world of grade, I won't go, it's a huge broad, the methods, the grade methods have been published over 50 papers, and there's just so much to be said, but I think I'm going to hone in just on one or two special features to help you understand and to put in perspective the recommendations. In grade, the recommendations come out in two flavors. There are strong recommendations and conditional recommendations. And overwhelmingly in pediatric PCC and in other PCC, the majority of the recommendations came out in that conditional category and not in the strong category. And what that means is that after evaluating and going through the grade process, it was deemed that it was not a slam dunk in favor of a particular approach to testing or treatment, but actually there was a little bit more of a narrow balance between benefits and harms. This is often because, and related to the fact that the evidence was something we were not necessarily all that certain about. We frequently found ourselves in the 1+ or 2+ category. That's low or very low certainty in the evidence. And rarely did we find ourselves, although occasionally we did, in the moderate and high certainty, which would be the two circles on the right. We also had to consider values and preferences, and it was clear that this would not be one size fits all and that personalization was required. So for conditional recommendations, the majority of the PCC pediatric recommendations, we give a direction to the recommendation, but we fully appreciate that it requires individualization and for providers to work with patients and their values and preferences and their family members to decide which is the best way forward. Next slide. So bottom line, our recommendations, especially the conditional ones, would suggest that most people would want to follow the recommendation, but many would not, and that is perfectly okay. Next slide. We developed another kind of guidance called good practice statements. So this is different than the conditional or strong recommendation. Good practice statements we felt were very important types of guidance to make. They don't rely on evidence in the same strict structured approach as systematic reviews, but still they, I think, are best characterized as necessary, but often unsurprising guidance, a little bit like a motherhood and apple pie statement, but still very important and very worth reminding providers and patients of. And they're kind of infallible. They're overwhelmingly supported both by direct and indirect evidence from different patient populations, different conditions, and I'll show you examples of those as we go to the recommendation phase. Next slide. So at the end of the day, we found 19 questions to focus on. 5 lended themselves to these good practice recommendations, good practice statements, and 14 recommendations. As I alluded to earlier, the evidence was often limited. We often had to extrapolate from the adult world, and the new evidence coming forward is particularly limited and it is not as frequent as the studies that came out in the 2021-2022 period. We also adopted something called, that was I think unique to pediatrics, called the precautionary principle, where we were somewhat put a bit of a skeptical eye on some of the treatments, realizing that we don't have all the answers. We don't want to expose children to interventions that may have known or unrecognized risks. So that flavored many of the recommendations that will eventually come out. Next slide. So here's our very first good practice statement, and it may seem obvious, but I think this actually responded in a way to Heather's comments and advice to us. And I'll just read here: healthcare professionals, the initial evaluation of children with persistent symptoms after COVID-19 infection should be a comprehensive one. It should not be, that includes not dismissing the concerns and not overly rapidly putting a diagnostic label on, but it involves a comprehensive assessment. It has to be accessible, appropriate, culturally responsive, include consideration of pre-existing conditions and other factors that may be contributing to symptoms. So we went back and forth on this many times, but we felt that this was the most comprehensive way to ensure that the healthcare providers will be providing empathic and comprehensive care to children and adolescents they were seeing with suspected PCC. Next slide. So here's another one. Lifestyle interventions. Best came as a good practice statement, very, very strongly supported from other conditions that resemble a PCC. And again, we know that these are good things for every child, and maybe not even necessarily ones with PCC, but they emphasize sleep hygiene, nutrition, hydration, social interactions, and that especially when the fatigue symptoms are prominent, these kinds of lifestyle interventions are most helpful and can provide additional benefit that may even go beyond PCC. Next. We spent lots of time and got lots of input around school adaptations and spoke to people who were involved in school policy. And we wanted to make this as welcoming and permissive and helpful as possible. So we created this good practice statement that school programs for children and adolescents should be meaningfully adapted to accommodate specific symptoms and needs. So it's not a one-size-fits-all. It works to address the needs of that particular child, be they physical challenges, cognitive, emotional, and that essentially schools should, as much as possible, going almost as far as bending over backwards to ensure that these children receive the accommodations that will ensure their success, and yet ensure that they are not stigmatized and ostracized and treated differently than the rest of the school population. So I can let you just scan the good practice statement. We felt there was multi-component. It had to have features of working with families, working with educators, and hopefully once this goes for public consultation, we'll have a confirmation that this is one of the final good practice statements that can be included in this group. Next slide. You remember I mentioned about the dysregulation of microbiota and the gut flora involved in PCC. So that naturally led us to ask the question, should prebiotics, probiotics, the umbrella term is symbiotics, should they be used for children and adolescents with PCC? So I'll show you the recommendation as it relates to that. Go ahead, next slide. So this is that evidence decision table put together as an infographic that I spoke about earlier. So here we actually found that there was some moderate evidence, although indirect, largely from adults, that for certain symptoms and outcomes, there was a balance favoring the use of these agents, the probiotics, prebiotics, and what was really important for us is that we did not, through the world literature, adult and pediatrics, see any evidence of harms. Now, they're not free. They still will cost approximately $120 for, I believe it's a year of treatment. And we appreciate that not everyone will have the same values, but still most people will want improved outcomes and would be willing to take a chance or at least try symbiotics to see if it improves their PCC symptoms. But we did recognize that there is an out-of-pocket expense with this, and that led to us creating a conditional recommendation in favor of symbiotics versus no symbiotics for pediatric PCC. Next slide. So again, conditional recommendation, the vast majority of CAN-PCC recommendations are conditional, and we, at the end of the day, considering the harm data and the benefit data, we only came out with a low certainty around that evidence, also preventing us from making any strong recommendations. So conditional was the way to go. Next slide. This is what's coming up next. These are almost completed and will be out for public comment shortly. They talk about vaccines for prevention of PCC, the 10-minute stand test for children with orthostatic symptoms. We spent a lot of time discussing the value of screening for mental health. That's not necessarily screening with an instrument or tool, but just thoroughly evaluating for the coexistence of mental health conditions, adequate caregiver support. And then to address the brain fog issue, we have tackled the questions related to SSRIs, or antidepressants, as well as methylphenidate, or medications that are CNS stimulants that are used for ADHD. Next slide. We also are tackling a number of other supplements, if you will. We are looking at vitamin C, creatine, vitamin D, omega-3, and we are also looking at exercise-based interventions that are going to be forthcoming as well, including self-management strategies and whether being vaccinated can actually be used as a treatment for suspected or diagnosed PCC. And 15 is important as well. It's about the holistic biopsychosocial approach, that comprehensive approach that we referred to in the first good practice statement. Next slide. So I will turn things back to Wojtek for a few final comments and open it up for questions. Thank you.
Thanks so much, Eddy. So in highlighting the pediatric and adolescent topics recommendations and the overall process, what we'd like to cover here at the end of the webinar and get to the Q&A. I see some great questions added in the Q&A here in Zoom, is where you can find the recommendations. So we have posted as they were developed, and part of the process to ensure we have rapid process where the recommendations are issued as they are developed by the CAN-PCC collaborative with public consultation for each of the recommendations. We've put them out on this rec map. This is a free online tool that allows you to search for the CAN-PCC recommendations. And if you can go to the next slide, please. On the rec map, you will find the full recommendations list, plus plain language summaries or plain language recommendations. So these are also a more user-friendly one-page view of the recommendations. And the detailed recommendations provide additional information, including summaries of the research evidence, the full evidence decision framework that Eddy has just showed. So this is available on the CAN-PCC website. You can access it directly through the CAN-PCC website by clicking on guidelines in the navigation menu, or going here directly to canpcc.recmap.org. Next slide, please. We've also developed, as part of our knowledge mobilization efforts, resources specifically for patients, for healthcare professionals. You can find those on our CAN-PCC website under the resources section. These include, for example, the My Guide tool, an online tool for self-management, interactive infographics and online resource sheets summarizing the recommendations, and these webinars will also be posted to our resource page. For healthcare professionals, we additionally developed knowledge mobilization resources, including CME, continuing medical education, accredited webinars, an online education course on diagnosis, referral, and management strategies, and a tool called EBM Connect Canada, which is a training program for internationally trained health professionals covering evidence-based medicine and PCC. And with that, we thank you, Eddy and Heather, for the great presentation. What we'll do now is switch over to our Q&A session. We have answered, feel free to keep adding the questions. I've marked a few for answering them live. We've answered a couple through the text option. You can see them in the answered questions. In terms of the questions, there is two related questions around symptoms and the overall prevalence, and maybe I'll direct this one to you, Eddy, for speaking about the pathophysiology of long COVID or PCC. This is a question from Nandini. It's mentioned that anxiety is the third symptom. Do we suppose that it's not so much anxiety, but the body is experiencing vascular and biological challenges in nature? So this mind-body connection and physical and mental health symptoms such as anxiety and depression. Would you have a comment on that and how the panel addressed that issue?
Yeah, I think that's a great question and a great point. And I think the way we begin to understand this on the panel is perhaps thinking about it as a gray zone. And, you know, the mind-body connection is extremely powerful. And we know that a number of physical and biological conditions will, either through distress of the symptoms or through direct, presumably neurotransmitter and brain-body connections, trigger anxiety. Now, has that led to some PCC sufferers being perhaps written off or dismissed as having purely psychological problems? I can imagine it would have. But what we're trying to do with these guidelines is encourage a holistic approach, and to say that while you know, and I think Heather mentioned it clearly, it's the importance of validating the symptoms. Now, there is also a whole group of conditions called somatoform disorders, and there will probably be some affected with PCC who will fall into that category as well. So I think the key for us was awareness that this kind of tension between physical and psychological exists, and there is in some ways a vicious cycle of patients with clear physical concerns and complaints that are leading to psychological symptoms that also merit attention and merit treatment. So we think that by incorporating all of our recommendations when they're finalized, clinicians will be able to address both of these in an equitable, caring, and empathic manner. Thanks. And I don't know if Heather has comments on that question as well.
Nothing additional to add to you. I think you covered it.
Thanks so much, Eddy. There's a question here so around the prevalence estimates. So related to a few of the other questions in terms of, and perhaps I could look to address this. So in terms of the estimation here, Nandini notes there's reports that 6 million children living with long COVID as of fall of 2024. Eddy, you had shown on the slides the figure from the survey study of 293,000 affected by long COVID, and up to 1% or 1.3%, I believe it was, having had long COVID at some point in the US. Then we have the Canadian studies mentioned, and as well, Małgorzata notes issues in the definition and those used in the studies, which could be addressed as well. I won't read the full question. You can see it in the open questions in the Q&A. And in general, that was the challenge the panel faced, is the certainty of that evidence with varying estimates, anywhere from 0.3 to 5% of those having COVID-19 infection in the pediatric population in Canada. Then we have the estimates from the United States as well. And in general, what the group did is approach uncertainty in an estimate by considering the upper and lower ranges of these estimates. So up to 5% when considering the overall benefits and harms of interventions, as well as issues like costs, for example, when we apply it at the population level. So further and more definitive research on the current state as well of long COVID in Canada and the United States, but more interestingly and more relevant in Canada specifically. So these are the Canadian guidelines for post-COVID condition, is where the panel identified research priorities. Many of the studies, as well as Małgorzata mentions, these are older studies from, for example, with data from 2020 or 2021. So knowing the current data would help raise our certainty in terms of the effect estimates. But we took that wider range where the lower values may be an underestimate, the higher values may be potentially an overestimate. And we looked to see whether that would impact the decision. Last point I wanted to mention for the WHO definition, across the CAN-PCC guidelines, the central guideline development group had chosen to use the WHO definition, as that is the one most commonly used and was established at the time of starting these guidelines. And that the group also thought that in terms of our efforts, rather than looking to redefine the definition or update the definition, that our time would be best spent on synthesizing the research evidence about management strategies, assessment, diagnosis, healthcare system services, etc. So this is a potential limitation in studies we had to deal with. As you noted here, Małgorzata, the studies may have used a WHO definition, or they may not have used any definition or a author-defined definition. So that's something we had to deal with as well in terms of uncertainty. Not sure, Eddy and Heather, if you have anything to add to those two questions.
Yeah, I would, great overview, Wojtek. I would just say, you know, although we have some uncertainty about the exact prevalence, one thing is clear: even at the lower estimates, this is a huge public health burden, and hopefully the work of CAN-PCC will help provide the substrate for the advocacy that this group needs. If it's, you know, closer to the lower estimate or the higher estimate, the importance of not allowing multidisciplinary PCC clinics to be closing as they are is an important agenda issue for policymakers. Thanks.
Great, thanks for that. In terms of just addressing that about the WHO definition here, I see, would we be able to address and remedy this? I think in most guidelines, where there was uncertainty, the groups modeled a range of prevalence estimates and a range for the outcomes and for costs, for example. Next question, just following here. Thank you for adding the new questions to these. I think in general, one of the questions is what will, so Mary or Mary Jo noted, what to do with the guidelines in terms of what's next. So specifically here, with all the data and showing the evidence of many issues, infection, reinfection, how could we influence? And I'll paraphrase the question. I hope that's okay, Mayor Jo. And for those online, you can see the full question in the Q&A. How influence robust public education, risks of long COVID, how to prevent it, addressing vaccines, testing, I think you mentioned as well, air filtration, ventilation. So I'll just start to mention, these are the questions that we have addressed in the guidelines, and we had prioritized the questions across all 6 guidelines, including for the pediatric topics, with public consultation to ensure we are addressing the most relevant questions. So these questions around vaccines are being addressed. They have been published for the adult population. They will be published for the pediatric population shortly, as Eddy noted, in the soon to come. And other questions around air filtration, for example, those are recommendations that we have as the CAN-PCC collaborative issued. In terms of what would be next, in terms of what can we do to influence public education, influence policymaking, would be the part of knowledge mobilization and dissemination of the guidelines. These are the guidelines that are based on the best available evidence. They are evidence-based guidelines following a rigorous process of development, but also methods of developing the recommendations. And here's where we would advocate for the dissemination of the guidelines, essentially putting them into use to influence public education, to be able to facilitate discussions with healthcare providers and with policymakers as well. And there I'll hand over to you, Eddy and Heather, to add anything else about what we can do for the next steps.
Well, I mean, I really do have to just thank and tip my hat to Public Health Agency of Canada for recognizing the importance of this topic. And I think that when the PCC library is complete, healthcare providers, with all the resources and the plain language summaries, will have an extensive library of resources to work from that will help inform their care, both at the interpersonal level and in terms of specific things that they will be recommending for testing and treatment. And we still absolutely recognize that this is an evolving science. This has only been around for a couple of years. We know there's work being done in many areas. And I mean, if there is future funding, we can certainly come and revisit and update and take on new topics. So great overview, Wojtek. Thank you.
Yeah, Heather, anything to add from the patient perspective as to use of these guidelines? See a couple other questions in terms of working with pediatricians as well, in terms of advocacy, and just scrolling through the...
I think, as Dr. Lang said, it gives a really good base point and starting point, and it's certainly more robust than what currently exists. And there is a gap. We recognize there's a gap, but it's something to build off of and from, and continue the advocacy and awareness around it.
Thanks for that, Heather. Last question I can take, because we just have 1 minute for our webinar and there's quite a few unanswered. So what I'll mention to the group is feel free to communicate with us. We have our, for upcoming recommendations, still a public comment period. So in terms of addressing issues around diversity of the panel, including the experts we had on the panel, and in terms of patient-parent representation as well. One of the approaches we've done with the guidelines in general is that we've had this extensive public consultation to include broader perspectives, including a public member panel, as well as our open public consultation periods. It being a challenge that we have 10 to 15 panel members, and especially for pediatrics, needing to represent all essentially subspecialties. So I'm not sure that 69% of the panel here, just addressing the one question, was psychiatrists and mental health experts. We had pediatricians as well, and other specialists for neurology, for example, and in general for other expertise areas. So I wanted to address that as the process also having broader consultation to address potential limitations and who we could involve on the panels. In terms of concluding questions. If we haven't had a chance to get to additional questions here, I see about the biomarkers, for example, about specific other interventions. One of the general steps or next steps for us in terms of the CAN-PCC guidelines is to identify the future research priorities, to seek additional funding as well to continue the efforts. That is where we would look for being able to maintain these guidelines and being able to update them in the future as well, with the project concluding with the approximately 100 plus recommendations we've developed. And as well as research emerges into the future, we would need to revisit specific recommendations and keep them up to date. What we will conclude with today is to thank you, just in terms of timing for the webinar, and to please visit us online on the canpcc.ca website and to view the recommendations through the rec map and view our other resources that we've provided. And I'll just hand back to Eddy and Heather for any concluding thoughts.
Thanks for the incredible engagement on the questions, and we know that this is a topic that raises passions. We know there's a lot of investment in a lot of advocacy groups out there, and we welcome continued collaboration to make the world better for patients and children, especially children and adolescents suffering from this condition. Thanks.
And lastly, what we want to have is your thoughts on the webinar. We want to hear about your feedback for the webinar. We appreciate the in-depth engagement from the group throughout the process as well, through our public consultations and through participation of all the groups on the CAN-PCC working groups. You can also stay up to date if you want to. Oh, sorry. And you can also stay up to date by, again, engaging with our website and stay up to date on our projects through signing up for our newsletter. So we'll conclude there. Thank you all for today, and really appreciate you joining us today.
Bye, everybody. Thank you.